Hackensack Meridian Children's Health is comprised of 2 nationally ranked children's hospitals by U.S. News & World Report and are number 1 in New Jersey. Hovnanian Children's Hospital in Neptune and Joseph M. Sanzeri Children's Hospital in Hackensack, as well as pediatric inpatient and outpatient services at JFK University Medical Center in Edison. With access to expert pediatricians and over 200 pediatric specialists across the state, Hackensack Meridian Children's Health prides itself on offering specialized pediatric medical care and surgical expertise. To learn more about Hackensack Meridian Children's Health, visit hackensackmeridianhealth.org/kids. Welcome back, everyone, to the Mom with Moms podcast. We are continuing our family healthcare series today with Hackensack Meridian Children's Health. Our guests today are Dr. Jessica Scerbo, Interim Chair of Pediatrics at Hovnanian Children's Hospital at Jersey Shore University Medical Center, and Pediatric Hematology-Oncology Division Chief. Wow. And Dr. Mark Kayton, who's the Pediatric General Surgery Division Chief at Hovnanian Children's Hospital, which along with Joseph M. Sanzeri's Children's Hospital are ranked number 1 in the state by U.S. News & World Report for pediatric care. Our topic today, that's a mouthful, but it's all great stuff. Our topic today is vascular anomalies, which I am very green to this topic, so excited to learn more, and how dedicated programs through Hackensack Meridian Children's Health are helping families. Welcome, both of you.
Thank you, Kay. It's nice to be here. That was a mouthful to say,
yeah.
All those terms.
But definitely the right people to speak on this topic, right? So thank you for joining. I, up until like a few days ago, I didn't even know the term vascular anomalies, not going to lie. So chatting a little bit beforehand just to kind of get some context into what we're talking about here and why it's important for families to be aware of and to kind of, to take a note, especially I think if you're expecting, right? Yes. Okay. So diagnosing and treating vascular anomalies can be a complex and confusing process for families. Let's start with the basics. What is it and what causes it?
So very simply, it's just abnormal blood vessel formation. Your blood vessels are supposed to go from very large to small. And what happens is sometimes they get tangled up as part of development. And because of that, it can lead to complications like abnormal growth of those blood vessels that can cause damage like bleeding or pain, or cosmetic issues as far as enlargement of a limb or ulceration or bleeding on the superficial lesions.
Okay. So is this something that people are born with always, or can you develop them later in life?
So a lot of that abnormal formation happens in the fetal period,
okay.
So during development. So when you see it is a variable. Some people may notice it right at birth. Those that are internal may be found later, but that process typically starts in utero.
Okay.
And what's fascinating about this field is it's very special to pediatrics, but it's also very special to have a group of specialists who bring together a meeting of the minds to be able to diagnose and treat these conditions, whether it's going to be in the medical realm or the surgical realm.
And that's based on the size and the complexity and what, I guess, if it's something that needs to be treated, right? So if it could be surgically removed, or you need to keep an eye on it. So vascular anomaly is, does it have like different names? Like you mentioned the port wine mark, and
yes.
Is it strawberry marks, right?
Exactly.
Okay.
And so that's what also makes it very complicated, right? You may have heard many, many names referring to this umbrella statement of vascular malformations. It could be a strawberry hemangioma or otherwise, a strawberry birthmark.
Okay.
Those can be very transient, meaning it's going to get better on its own, and our determination of if we need to treat it depends on where the location is, what kind of issues it's causing for the child, versus, say, something else that's within the brain that is a concern lifelong. So it gets complicated in that there's many different names that are used for these malformations, but also there's many different treatments. And so in order to sort of simplify or demystify that, our subspecialty clinic really comes together to help you identify exactly what to call it, because it could take you down a very different pathway. And then how do we need to approach it? Because it's not one size fits all. They're all very different depending on what we think the cause is.
So what does what, I guess, are there different causes then?
Yes,
Okay.
sometimes it's genetic. We know that there's some genetic mutations or changes that could trigger the growth or make it more likely. Other things are associated with what we call syndromes. So that malformation is just one piece of the puzzle, but you may have an enlargement of an extremity that goes along with it. We're more likely to have those lesions and size. And so, we can then determine, is there a genetic cause? And interestingly, a lot of those may have a medication that could directly go and target that mutation and help these things shrink, but also perhaps prevent further complications.
Okay.
And part of the novelty of our field is being trained to recognize patterns in developing children. And that's why this topic has really been sort of confusing and a mystical area for physicians who are probably extremely well-trained but may specialize in taking care of adults. We partner with many of our regional dermatologists, and I think this is a tough challenge for them because part of the recognition of what's going on comes from our training and our work at a children's hospital about knowing what to expect at different stages of development of an infant and child.
Okay.
And what patterns to look for with the growth of vascular malformations. Dr. Scerbo is treating a patient who has hemangiomas in her liver. And this is, of course, this is invisible. So this is one end of a spectrum that starts with what seems to be a simple birthmark, but knowing where to check internally is a component of our work.
Wow. So, okay. Number one, if you are a new parent and your child comes out with what looks like what they would just call a birthmark, right? One, are they predominantly like always on the upper like neck and face? Two, is it something that like parents should be alarmed about when they see, are they like always red? Like what, I guess when you're in the hospital, like there's doctors going to be able to kind of tell you, but like, well, what would you initially think and do in that circumstance?
So I can answer this from two fronts, as a physician, but also as a mom of a child who had a hemangioma.
Oh, wow.
You could certainly, most of the time, it may be there at birth, but most of the time it's going to start to erupt around 2 to 4 weeks. So you're no longer at the hospital. You may not be at your pediatrician, and you start to notice a small red dot typically. It may just be very, flat. You can't feel it, but over the course of weeks to months, it actually becomes raised. It becomes like a red, waxy appearance. And so as a parent, you start to think, was this an injury? Is this something that maybe it was rubbing, right? And so you say, why is it growing in size? And that's sort of what triggers you to say, this is more than just a beauty mark or a birthmark. This is something that's changing.
Okay.
That's not just staying the same size. And, again, we always say, you go to your pediatrician, you could get it assessed, but certainly those are the signs that suggest that this is a little bit more something that needs attention.
And it's not something that would get bigger because the child is growing. It's more like growing
Correct.
at a more rapid rate.
It's growing faster than your child
Got it.
would.
But
Okay.
it's funny, Kate, parents blame themselves, and we like to be able to really take the weight off the shoulders of a parent and say, this is appearing on your baby, but it's not something that you did. You didn't put on the wrong baby lotion. You didn't forget to take your prenatal vitamins. This is part, in some cases, part of the development in infancy that some of our patients undergo.
Wow. Okay. So how are they detected when it's internal? Is it something that raises in the skin? You mentioned on the liver. Is it like an MRI that you'd have to, like, how would you even know that they're there?
So sometimes there can be what we call cutaneous lesions or lesions on the skin, and based on the number of them, even if they're teeny tiny, if they're 5 or more, that's a significant marker that you could potentially have them internally.
Okay.
But just to play out, it does say there's nothing at all on your skin. What
Yeah.
you may see is irritability. Your child may have what we call abdominal distension, or their belly just seems to look a little bit bigger. Even after they've burped or gone to the bathroom, it still seems more distended. If they're vomiting, the patient that Dr. Kayton was referring to really presented with inability to eat, because as those lesions start to grow, so does your liver in size, and there's only so much space inside your belly, particularly at that age, and so it just puts a lot of pressure on your stomach, and so you're not going to be able to eat as much. Again, you may have more vomiting. You know, all babies will do a certain amount of spit up, small amounts, but if it's large amounts of feeding, if you notice that they're really not able to eat, they're vomiting and they're not urinating as much to signify that they're not, getting their nutrients, those are all signs, again, to refer to your physician to assess and see. And eventually it gets to a size where your liver, you can actually feel it from the outside, or, a professional will be able to say, it seems like your liver's enlarged, because it does grow, again, substantially in a short period of time. So your body just can't accommodate that as much.
Okay. And it's always in the liver.
If it's internal, it's most commonly in the liver. It can be in other locations. They could be in your brain.
We're treating
right?
some that have shown themselves as bleeding or irritation on surfaces like the mouth, for example. And so those require that we really ratchet it up to a higher level, because if a baby is having bleeding in the mouth or can't latch onto a bottle, to any parent, that's urgent. So to us, that's urgent too.
Yeah.
And when necessary, we bring all the resources of the Children's Hospital and get treatment started immediately sometimes.
There are some what we call risk factors, or certain populations that it's more likely to be seen in, and that's premature infants, females, and twins. So it doesn't mean that it has to be the case, but certainly those are the groups that we watch a little bit, closer.
Will twins have the same one?
Not necessarily.
Okay.
Believe it or not, it could be just one twin, but
Okay.
we know that those are the things that may make it more likely. It is, when we say genetic, it's not mom or dad gave it to me. It's just some of them have genetic changes within their cells that make it more likely to grow.
Okay.
So we always, make sure that we counsel the parents that it's not something that you pass down to them. It doesn't mean just because they have a hemangioma or a malformation, their children will as well.
Mm-hmm.
So those are always things we like to emphasize.
Okay. What is typically the challenge in receiving diagnosis and expert care?
Getting to us. Because if your child has a blemish, a bump, or a subtle symptom, families don't always know where to go. And pediatricians are usually very savvy about this, but some of these are rare situations. So finding a specialist has become a very confusing maze in our part of the country, and that's why we want to be here as a resource in Monmouth County. Some of the care we find is sent to plastic surgeons.
That's what I was going to say.
Right.
Where would they be directed to?
Right.
Okay, interesting.
Now, I'm trained as a general and pediatric surgeon. I love surgery.
Uh-huh.
It's not always the right thing for everybody's child, particularly because the current state of this field means that a lot of these can be treated with medical or minimally invasive maneuvers.
Mm-hmm.
And coming to a program like ours, I have to be humbled as a surgeon who works there. I'm not always the person with the immediately relevant therapy. Sometimes it's a down the line thing, and sometimes it's a not at all thing to talk about surgery for your child.
Okay.
It's available. It's available though.
It's available. Yeah, we just did the highlight on the Scrub Club.
Good.
I actually went to the Hope Tower and we just shot it, so it hasn't come out yet. But it's also a great program that they have if that is something that children have to face. How can you tell if a birthmark or other abnormal mark might need to be assessed, and how would you get started? And now, my mind is spinning because I have I've always had a little red thing, and I'm like, oh my God, is that a problem? A little, I think it's called a blood blister that never goes away. Is that part of what you would look for?
So that may have been a
Do I
very
have an
small anomaly, but If it's stopped growing, if it's stayed the same size, it's unlikely to need further treatment.
Okay.
Again, those are situations where we say, well, if it's cosmetic, if it's in a location that you would prefer it to be removed, that's something that could be addressed.
Okay.
It's really what signifies that you should be assessed is if it's growing.
Okay.
If it's growing, if the area around it is an area of concern, meaning say it's on your face and it's growing and it could potentially impact your vision. Or we have some patients where it's at the tip of their nostril, and as it grows, it could obstruct your breathing. Babies are predominantly breathing through their nose, so losing one of your nostrils can be significant. So if it's somewhere in a location that could impact your baby's development, we most certainly want to see them quickly.
Okay. 2 questions related to that. One, the mark itself, say it is not something that could potentially be life-threatening, but is more cosmetic, and you've ruled out any chances of it being, a real threat to a person's health. Is it possible to have them, like a plastic surgeon, to kind of have them remove, especially if it's like a stain of some kind, or do you have to live with that?
Yes. So if we feel like it's a stain, that is something that we could, with our northern colleagues, with Dr. Shin and the Vascular Birthmark Clinic at Joseph M. Sanzari, they have a laser that can then be used to try and decrease that pigmentation.
Okay, interesting.
To improve that.
Is that kind of a new innovation in technology, or?
So it's something that's been used for a while in the dermatology realm, and again, we're kind of using that even for hemangiomas, even for things that are meant to be transient or improving. If we notice that pigmentation remains, it almost goes through a near what's called involution or resolution. It gets flesh colored. It can sometimes resemble a scar until it fully resolves, but if that remaining scar has a little bit of pigmentation to it, then we would ask dermatology to go ahead and use the laser to try to decrease that. But a lot of these, our expectation is that they'll go away on their own. So to Dr. Kayton's point, we would try and postpone any type of surgical procedure unless we felt like it was past the point where it's no longer going to shrink in size, and now we have to think about additional planning.
And then if the bump or the vascular anomaly is in a functionally or cosmetically important place, we're in a better position once we've given some time for monitoring and observation to make a recommendation to the family that maybe you want to consider having it removed at this point.
Okay.
It's usually not the first step, and families are sometimes hesitant to put their young child under anesthesia. So we're able to have those discussions in a sort of a well-planned and method with good advice in terms of the timing and how long is too long to wait and how much longer can you really wait.
Right. So we talk about awareness, what to look for, but I'd also like to address the why, right? So why do you need to remove them? What are the potential, not for scaring anyone, but what are some worst case scenarios where, they really need to be removed and you really need to address the anomalies because of what could happen, I guess based on where they are in your body, what happens? Right.
The number one reason why we would want to act is if it's in a location, again, that impacts your development.
Okay.
If it's going to impact the baby's ability to develop vision, right? If you imagine if it's blocking a area of your visual field and you're young and when you have this, that field is gone. You can't redevelop that later in a year when it shrinks.
Wow.
So if we need to bring that down immediately, then we would do medical treatments that will help shrink that, stop that growth process, so that we can maintain function.
And what are the treatments? Is it like radiation or?
So there are actually 2 medical treatments that we tend to use. If it's in a low risk, we could take a little bit of time. Yes, we want it to start to shrink, but it's not urgent that it does. We would use a topical.
Okay.
It's actually an eye drop that's used for glaucoma.
Oh.
And it shrinks the blood vessels, and that's how it helps it to start to go through that process of resolution. And so you would just apply a drop 3 times a day to the location. If it's something that we need to make that go through that process of resolution faster, we use an oral medication, which is similar. It's a cardiac medication, a beta blocker that shrinks your blood vessels. We use it for high blood pressure and things like that. But it actually has been shown to start to shrink these and bring them down much faster than they normally would.
And that medication, propranolol, is now well established in our field. But here's the interesting thing, is that it's a heart medicine. So it's very hard for a pediatrician or a dermatologist or a surgeon or even a hematologist to prescribe it solo. So we are in a close-knit partnership at our children's hospital with our pediatric cardiologists who can run a screen to make sure that a child's heart is suitable for a medication that has a small chance of having some effects on the heart as the child grows and develops. And often we can get a level of confidence by having a cardiologist right there in the clinic with us that, you know what, this is going to be an innocent medicine that's probably not going to have any side effects. And that gives us a little bit more of a cushion of knowledge and wisdom to move forward with prescribing something, even for an infant.
Interesting. Okay. Is that Dr. Alpert?
Dr. Alpert's group and Dr. Sharon Weinberger are
they were both
partners
on the podcast, but Dr. Alpert was actually my cardiologist when I was a kid. Small world. And then he was also on the pod a couple of years ago and knows my cousin who is a pediatric cardiologist, but like in Southwest Jersey. So we it's a small world. So, okay. And what is the so they would have to be on the medication long term or until it shrinks?
It's until it shrinks. So we typically would keep you on till a year of age because that's sort of the textbook time where it's going to go away on its own. We've learned through national data, not just our own program, but if you stop it before that time, there is a chance it could start to regrow again because the blood vessels are still active. Okay. So we typically keep you on just over a year of age.
So is that something that you use to treat when it's in the liver too?
Exactly.
Okay.
Exactly.
Because you can't, would you then, if it's not, would you have to remove part of the liver?
Right. So we couldn't get that topical wouldn't be an option because it's not something that we can access. Taking it orally allows us to, again, shrink it non-invasively. If for some reason the medication wasn't working, it continued to grow in size and we were concerned that it was going to damage the liver itself, then those are areas where we could come into play with surgery. But typically it's throughout the liver.
There's some specialized treatments called embolization. It can be done by suitably trained radiologists in the context of a multidisciplinary hospital. And it's rare to have to do that, but it's important to have access to folks who are knowledgeable about that.
Interesting. Okay.
And when we're talking about the cardiologist, just one thing I wanted to bring up is that we pre-screen. So if you had a concern and you send your child, typically we'll ask you to send some photos. And with our nurse navigator, she will bring that information to our core team. We review it and say, okay, this is something that we are thinking of offering, that oral medication. We'll make sure pediatric cardiology is at your visit. If we feel that it's going to need imaging, then we would start to set that up in place. We try to make it really one-stop shopping because what we talked about, it's hard to find the right person because they may be, sent to different specialties. It also takes a lot of time. If you initially came to my office and I said, I think we're going to need this medication, I'm going to send you to cardiology, that could take 2-3 weeks to get clearance. And then you come back to the office. Or if we need to do imaging, that could take additional time. If we have it in this model, you could see those providers all in one visit, which shortens it. But if additional things are needed, our nurse navigator could get those going to really try to put the families at ease that we have everybody that we need for that evaluation available to their child as quickly as possible. So you don't have to do a lot of the discovery. The founder of our vascular malformation clinic, Dr. Stove Schulman and his family, they did just that. They had to go to New York City to identify a physician for the vascular malformation that their daughter Megan had, and then did a lot of the navigation for themselves. And so again, it's time consuming, but also all of that worry of am I getting to the right place? Do we need to be treated? Is this too much of a time lag to get treated? And so that's really why they wanted to implement this program, so that, families in New Jersey don't have to travel and that they don't have to navigate getting those services on their own, because it's not something that every physician or pediatrician is going to know exactly where to go. They might say, let's start at hematology and then they'll guide you, or let's go to dermatology and they'll guide you. But those may also have significant wait times, or they may also then send you to another place. And so that's where parents sort of get lost in that web of who's the right person, should we be doing something sooner? And this way it sort of cuts down on all of that.
We found that a lot of our Monmouth County families were told right off the bat, oh, this is rare, we don't know what that is, and you better go to New York or Philadelphia. And we want all that expertise to be showcased right here.
Yeah.
And we feel very lucky to have brought together a number of people in different medical specialties to get this initiative going.
Right, which brings me to my next question, which is to tell us about the Megan Schulman Vascular Anomalies Clinic at Hovnanian Children's Hospital and what to expect when you go there.
Well, Stuart and Michelle Schulman are a family that, a couple that raised their children in Freehold, and they were very vocal in identifying with us and partnering with us to help to form a program that can take care of these conditions here in Monmouth County.
Wow.
So sometimes it takes a spark of a family who's had an experience, a family who's had a sick child, and all of the feelings and enthusiasm and resources that stem from them and their friends and their associates thinking through, wow, what was missing when we were here and we needed it and it wasn't here.
Mm-hmm.
And I think that's a very powerful motivator. So we've listened to their story. We've responded as a children's hospital and said, you know what, we can do this. This is not, there's no physician that does vascular malformations in children 24/7, 365. It's been dispersed between hematologists, surgeons, all the specialties we've talked about, cardiologists. But what we can do and what we have done now is brought all these specialties together in a very concrete way. I mean, let's talk about like how we do the visits with patients even, right?
Yeah,
so
absolutely.
You may bring your child in and you might have 2 or 3 specialists evaluating your child at the same time. And I think families are astonished because they think, well, we're going to come in at 8 in the morning, we're going to be here all day long, we have to see one, then the other, then the other. We're not going to do it that way. We haven't modeled it that way in our program. We've tried to be relevant for the needs of families, knowing that this could be a small problem or a big problem, but we don't need to sideline your whole family necessarily for an entire day. If we can bring 3 specialists in to see your child and talk to you all at the same time.
Wow.
We've done that many times. It's an investment of resources and time and passion for those of us who are really steeped in the care of little children. But this is a joining of what we feel is needed for families to feel that we're accessible to them, and also what we've experienced. I think all of us are parents and have been through some sort of rigmarole at some time, even for a minor problem that sidelines your family for days at a time.
Right.
It doesn't always have to be that way.
Okay. So I'm just kind of guessing, like if you'd be able to see a specialist depending on how big the anomaly was and where it's located, that perhaps you would need to have like a neurologist there, or depending on I guess where it needs to be removed and what it's going to be touching. Is that kind of what you're describing?
So there's a core group of specialists who can counsel and often start treatment if it's needed on the majority of vascular malformations, many of them hemangiomas in babies, other varieties exist that we've touched on, arteriovenous malformations and something called lymphatic malformations. And then from that core group of specialists, then we branch out because every case is different. And that's the funny thing about carving this out as an area of specialization is you can't be like an arm doctor and do this, or like an earlobe doctor and do this, because your blood vessels are everywhere in your body. So this is very challenging for
like where it affects.
Right, because something might be affecting somebody's nose.
Yeah,
something might be affecting somebody's toes.
Yeah,
literally. So we have to branch out to the relevant consultants, and that's why we and the Shulman family were very resolute about this. Isn't the kind of thing that you can set up in a doctor's office here in Red Bank on Broad Street. This has to be within the confines of a children's hospital, because you're right, Kate, if we have to get someone to a neurosurgeon, well, we got that. If we have to get someone to a plastic surgeon or an ear, nose, and throat surgeon, we have them too.
And you got a guy for that.
Yeah, we got a guy for that, or a woman for that. And so these are accessible. Now, I'm not saying that we have 14 physicians lined up to see every child, but we want to make the right networking happen promptly.
Okay. Once treated, do vascular anomalies need to be monitored or addressed in the future?
So for those that are going to remain, we will continue to monitor them in the future, because there's always a potential that there could be growth that happens. It's not that it's just continuous growth. There can be periods of time where it's not growing at all and then it begins to grow, and those can place you at risk for bleeding. So those are things that we certainly monitor for. For hemangiomas that we focused on a lot, because that's the primary birthmark that they may see, those typically, once it's gone through its period of resolution, we can then send you back to your pediatrician. We don't necessarily have to follow those lifelong. That will continue to heal and actually become less obvious, almost imperceptible, as the years go on.
Do most of them are evident at birth, or is it kind of a mixed bag in terms of when?
It's a little bit of a mixed bag, but somewhere, the large majority around 2 weeks of age, you'll start to see it erupt. Are they there since birth? Absolutely, but they may be below the surface so that we can't detect them.
Interesting. But you can detect them as an adult?
Yes.
Okay.
Yeah.
It may seem overwhelming for families, especially, I wouldn't say new moms, because I think each birth is different, right? Each child is different. But maybe you've had a very healthy pregnancy and, you're not expecting any complications, and, and then you're faced with this, right? With your child being born with something, and you're maybe not sure, kind of handle it. What do you recommend for families to keep in mind?
Well, first of all, that's happened a few times because we have a very busy obstetric service at Jersey Shore and a newborn unit. We've identified and counseled some families, in some cases within 60 minutes of the birth of their child.
Right, like that's a big...
Right,
yeah.
So I've been summoned to our newborn nursery, to our neonatal intensive care unit, with very well-trained colleagues saying, we think this might be one. Could this be one of those?
Yeah.
And Dr. Scerbo and I, on several occasions, even in the last few weeks, have said, yes, hook this family in with our program. And that's within 60 minutes of birth. So that can be tremendously reassuring for families sometimes.
Your proximity to the NICU and the, postpartum floor is very close then? You're nearby? Okay.
So we're housed in Hope Tower, which is on the hospital campus.
Yeah.
So our services are able to do a consultation immediately. If we feel that it's something that can come to the office, our nurse navigator will send that over immediately.
Yeah.
So she's very integral in making sure that we can bring those referrals in quickly. And again, make sure she'll follow that family throughout, from the first visit to anything additional. If they require medication, like the propranolol, depending on the age, they may need to do an overnight stay at the hospital. And so she will work on all of that piece. She's pretty much there with them throughout that process.
Wow. Okay. That's incredible. The Hope Tower is just this like beaming light of resources and hope for families, and well, no pun intended, because we've had, like I said, we've had a lot of providers on over the last couple of years, and I think it's so incredible that so many families can not only, be treated there for one thing, but that there's, a doctor that practices something where they can, then literally just go to the next room or the next floor and, get some guidance in terms of, getting the best care for your families. And between that and being rated number one for U.S. News World Report, the level 1 trauma center, right? Which is
level 1 pediatric
trauma center.
For that, the first in New Jersey and the only in New Jersey.
Yes, it's I'm aware, but we're working on spreading the word through the Mom with Moms network because it's newer within the last 3 months.
Yes.
Yeah. Okay. And an incredible accreditation, and just really valuable for parents to know that it's in our backyard, and that you no longer have to, if you feel that you would need to travel to hospitals outside of New Jersey, that you no longer have to. It's great. So there's just so many resources that are available. I grew up in Monmouth County, and I think Jersey Shore was always like a good hospital to go to, but now it's really, really great. So thank you so much for sharing. So we're at the Hope Tower. We're going to put in the notes where everyone can find more information, where to reach you. If you're not sure, if you're looking at something, or maybe, you're not confident at what your pediatrician has kind of guided you to, what would they do in that instance? Like if they're not being referred, can you just make an appointment?
Absolutely.
Okay.
You can call yourself. We have the Vascular Anomalies Clinic phone number.
Okay.
And that's something that they can link in. You could also call Hope Tower and Pediatrics and ask them to direct you. But that's something that we could, again, self-refer, absolutely.
Okay.
And then we could evaluate and say, the core team is going to look at that and is sure if it's something that needs to come in, we'll make sure that you get there quickly and get the answers that you need.
Great.
And help set that up. They can absolutely do that.
Thank you so much. Thank you for the information and for helping so many parents in our community to get the best care that they can. Thanks for joining.
Thank you for having us.
It's been a real pleasure.